Hello, my name is Martin Hoenigl. I'm Associate Professor of Translational Mycology at the Medical University of Graz, Division of Infectious Diseases, and also still have an appointment at UCSD in San Diego. Today I will talk about the relevance and importance of guidelines by medical mycology societies for clinical laboratory and staff. These are my conflicts of interests. You see, having a lot of snow is not in there, but Austrians are still skiing. So the talk today will focus on three different aspects. I'll mostly focus on the ECMM One World One Guideline Initiative, which is the broadest initiative we have seen in medical mycology guidelines, as it spans the world basically in multiple societies across the world. So first of all, I will focus on what are the guideline characteristics of this initiative and why they are unique. Second, I will talk a little bit about why do we need these new guidelines. And third, I will talk about what are the actual recommendations in these guidelines that are relevant to treating clinicians and laboratory staff. So starting with the characteristics of this new guideline initiative and why it is unique. So most important, very important, this new guideline initiative overcomes the limitation of continentalism in guidelines. So far, we mostly had European guidelines or American guidelines that then had to be adapted by local societies to other parts of the world. But really, the guidelines nearly all originated from the US or Europe and did not really involve a lot of expertise from outside these two continents. Another new thing in these guidelines is that the guidance for diagnosis and management is stratified by high and low resource settings. We utilize a global network of the ECMM Academy and ECMM Excellence Centers to make sure that this guideline is not only for the world to read, but also created by authors from around the world. It's also an orphan disease guidance where all different disciplines are involved in interdisciplinary management of invasive fungal disease. As said, we have professionals from all UN regions that contribute their expertise to these guidelines. And luckily, we're also very successful in recruiting other societies to join these initiatives. And this includes ISHAM as a worldwide leading society in mycology, but also the American Society of Microbiology joined, among many other societies that are endorsing the guideline. But the ECMM, together with ISHAM and ASM, are really the main drivers in terms of societies of these guidelines. Another very important characteristic of the guideline is the time flow. We've seen in the past that sometimes these huge guidelines, for example, on Candida or Aspergillus, take many years from the time they are created until they are published, up to 5 years or even more sometimes. So for us, it's very important to bring out guidance documents that are published very fast and still reflect the current evidence that's available, because our field is moving fast in medical mycology. And you see here, we therefore have very strict deadline. We have 30 days time where we invite potential experts, then 7 days where the convener collates the responses, followed by 14 days where people need to confirm membership in a guideline group. Then there's the work specification for each expert sent out within 2 days, 120 days for developing the doubleized recommendations, and then 60 days for drafting the manuscript, 14 days for circulating the manuscript, final decision by the guideline convener and guideline coordinators within 7 days, then a 30-day public consultation period, 30-day final review round, and then submission of the manuscript. So optimally, this whole initiative could result in publication of the guideline within less than a year. But even within a year is very fast compared to all other guidelines that are worldwide guideline initiatives that had been started before. And why is this fast turnaround so important? I mean, first of all, of course, we are now living in times where we will have a number of new antifungal classes available soon. So it's very important that the guidelines reflect the current availability of antifungals and the current evidence that we have for using them. And this is just showing you, some of those new ones, including Fosmanol GPIX, Olorofim, Opelconostal, Rezafungin, or Ibrexafungerp, that will be available for clinical routine within the next few years. Another characteristic of this guideline is that we really have authors from around the world involved. And this does not only include being a member of the guideline committee, this also includes being a coordinator. So some of the drivers of these guidelines are also circulating from different UN regions from around the world. And you can see here a map, and this is only reflecting the first 4 guidelines, the Mucormycosis, Endemic Mycoses, rare yeast, and rare molds. You see already a lot of representation from different continents, different UN regions from around the world. We have been getting even broader more recently with Cryptococcus, Candida, and Aspergillus. So this is only reflecting the first 4 guidelines. So the world is more colorful right now than it has been before. And how is that possible? You will probably think that ECMM must be a very rich society to fund such an initiative with guideline coordinators and contributors from around the world, to bring them all on the same table and fly them in. But in fact, I think the main thing we used here was technology. So we use basically YouTube videos, we use online meetings. So it's basically nearly all of the process is virtual in terms of creating the guideline. Of course, we then present this guideline in person also, or via hybrid conferences at different conferences. So we meet in between. But really the process that's very time consuming and needs a lot of interactions is mostly virtual. And therefore it doesn't cost too much money. And I really have to applaud here Oliver Connelly from the University of Cologne and his team, who set up all this video YouTube channel with all the different guidance on how to create the guidelines, what to do next, etc. And finally, once a guideline is published, we also have webinars that we then also publish via the YouTube channel so the whole world can see. And then I've showed you the authors that are really from around the world. We're also lucky enough and used a lot of outreach to really convince multiple endorsing societies around the world to endorse our guideline. And this is just an example. This is the rare mold guideline that was really endorsed by all the countries you see here in green, by national societies from all the countries you see in green, also by multiple international or continental societies like European societies. You see, we have not even displayed them in this map. This is just a display of national society that endorsed our guideline, but there are also multiple international societies that endorse them as well. Overall, basically 55 scientific societies who endorsed our rare mold guideline from 38 countries, and some of them, of course, very international and worldwide societies. And this is just one example, but this is true for all the guidelines we have published so far, and so far all the guidelines get published in Lancet Infectious Diseases. Another unique thing about the guideline is the guidance, because the other problem is, of course, once you want the world to read the guideline and use the guideline, it has to be useful for the world to use the guideline. And of course, we know in terms of resources, we don't have the same resources available around the world. So there are many places in the world where we only have more limited resources available, in low middle income countries, for example. Therefore, it's really important that the guideline is adaptable to the local resources. And here you see as an example the general guidance we have for mucormycosis, assuming that you have all resources, all different antifungals available, where you use liposomal amphotericin B as first-line treatment, except for those with pre-existing renal compromise, where we want to use isavuconazole or posaconazole, and then basically go on from there with response assessment. But this can easily be adapted, for example, if you don't have liposomal amphotericin B available in your setting, to your local availability of antifungals. And here is this example: no liposomal amphotericin B available, and then isavuconazole and posaconazole, both IV, become first-line treatment for mucormycosis. So what is the schedule of the One World One Guideline Initiative? So we have published so far mucormycosis. Then in the meantime, we have also, and I'll show you a little bit in the end, have been seeing the urgency for COVID-associated pulmonary aspergillosis emerging. So we published some definitions and guidance on that in 2020. In 2021, we published rare molds, rare yeast, endemic mycosis. Cryptococcosis is nearly done and will be published in 2022. And we will also publish Candida in 2022 and Aspergillus probably in early 2023. So we are really fast moving the different fungal pathogens and hope to have a first round completed by 2023, and then start again with updating, of course, our guidance. This brings me next to the point: why do we need these new guidelines? First of all, the epidemiology of invasive fungal infections is constantly changing. You see here on the left side a graph that shows you advances in medicine, including introduction of broad-spectrum antibiotics, intensive care units, organ transplants, the HIV pandemic, stem cell transplants, small molecule therapy, and you could also add here the COVID pandemic. And you see this constant increase of invasive fungal infections that we are seeing in our patients. The worldwide estimates currently are that there are 15 million cases of pulmonary and invasive fungal infections that occurred every year, including about 250,000 cases of invasive aspergillosis. It's also important to consider that the epidemiology is really changing because on the one hand, we are introducing mold-active antifungal prophylaxis in those patients at the highest risk, including, for example, patients with prolonged neutropenia after induction chemotherapy. And at the same time, there are new risk groups emerging. So we're in a constant race, and the risk groups that are currently emerging are mostly non-neutropenic patients with other severe underlying diseases, including patients in the ICU, but also, of course, solid organ transplant recipients, other patients receiving systemic glucocorticoids, and patients with structural lung diseases, and also those with solid cancer. For all patients, early diagnosis is important and followed by early therapy may improve survival. And one of these new risk groups, as mentioned, are patients with COVID-19 associated respiratory failure who end up in the ICU requiring mechanical ventilation. Here we know that the viral respiratory infection itself with the epithelial damage is one of the risk factors, but so is the treatment of COVID-19 acute respiratory failure with systemic corticosteroids, with dexamethasone, and also with tocilizumab. And when we look into multicenter studies here, the ECMM Kappa multicenter study that reported a median prevalence of about 11% with a range between 2 and 27%. And this has also been confirmed by other multicenter studies from France or also France and the Netherlands that showed a median prevalence between 10 and 15% that we are seeing in these patients in the ICU. There's still, of course, a lot of variation, so it's still important to know the local epidemiology, and this, depends on different burden of Aspergillus exposure, diagnostic accuracy, maybe also genetic predisposition that may be different between different centers. Here, just showing you what the risk factors are and also the confirmation, this French multicenter study led by Jean-Pierre Gagneux that found the same risk factors as in the ECMM multicenter study and also a prevalence of about 15%. Another reason why we need guidance and another indication that our field is constantly changing is, of course, the impact of global warming and climate change. And the most obvious implication of climate change is, of course, that some of these temperature-dependent fungal infections, in particular the endemic mycosis in the Americas, continue to spread to places where they have not been endemic. And this includes, for example, coccidioidomycosis, which has been very prevalent in Arizona, but now really is prevalent across California. And the first cases also are reported as far up as Washington State. So it's really expanding and will continue to expand over the next years due to climate change. But then climate change also leads to emergence of new pathogens that certainly at some point adapt to human temperature of 37 degrees and become human pathogens. And we really think that Candida auris is a story and a result of climate change, that Candida auris adapted to the higher temperature and now is an emerging and very threatening human pathogen. And then we also have, of course, the problem with resistance, which is constantly changing our approach. Here, of course, Aspergillus is azole resistance, which has been a big problem in the Netherlands and Belgium, but it's also a relevant problem in many other places around the world. And resistant cases are now also emerging in the US. Much of this resistance is really associated with triazole use in agriculture. But nevertheless, it's also something that we need to monitor and that requires guidance that is up to date for us to enforce clinically. And of course, this also affects Candida species, where we have these increasing proportions, now more than 50% already of non-albicans Candida species causing invasive Candida infections. And also in those, of course, we have increased concern for fluconazole resistance per se. And in some of these species, we really don't have good options for stepping down therapy in case there is fluconazole resistance. So that's also another important field where we need up-to-date guidance to help us make decisions. As said before, our main fight or main weapon that we have against the increase in prevalences of invasive fungal infections are to use antifungal prophylaxis. And we actually use that very successfully now in some of these traditionally highest risk groups, particularly patients after induction chemotherapy with prolonged neutropenia and patients after with graft versus host disease, so all hem malignancy patients, also after solid organ transplantation, especially lung transplantation. At the same time, we're not using it in everyone, and that has very good reasons, right? Because it also comes with some potential problems. The most important problem are of course the costs and the drug-drug interactions that are associated with azoles that are really the agents we currently have to use for prophylaxis because they are available orally. They have oral bioavailability. But there's also a selective pressure potentially of mold-active prophylaxis, leading to emergence of some of these more rare fungal pathogens, including rare molds such as Mucormycosis, Fusarium, Lomentospora, and Pseudosporium, but also rare yeasts that may cause breakthrough infections in these patients receiving mold-active prophylaxis. Of course, we have to emphasize that these breakthrough infections happen and they are associated with very high mortality rates, but nevertheless, the total amount of fungal infections is heavily reduced in those patients where antifungal prophylaxis is indicated. However, once we have a breakthrough infection, this becomes really very difficult to diagnose and treat, and we see many different rare pathogens now emerging and becoming more frequent. Generally, we say always we need a change of drug class and aggressive diagnostics. But when you really get into details and diagnose some of these rare yeasts or rare molds, you really need to adapt your antifungal treatment to the actual pathogen that you're identifying. And that's also where, of course, first for diagnosis, but then also for treatment, these guidances, these up-to-date guidances on, for example, rare yeasts and rare molds, but also Mucormycosis are very helpful. And I'll move on to bring you an example of a single center example of where we end up when we start, digging deeper in our single center data. And this is actually data from University of California, San Diego, where we are a relatively big ID unit with more than 50 ID faculty and a huge hospitals, I have to say, with many patients at risk. So here we did a retrospective chart review of all patients with cultures growing non-Aspergillus molds between 2014 and 2017 and found 23 cases of non-Aspergillus invasive mold infections. So we've found much more isolates, but these were really cases where we had proven invasive mold infections, including 10 cases of Mucormycosis, 8 of Lomentosporosis, and 5 of Fusariosis. So this is also very important because you may not see so many Lomentosporosis cases, for example, in Israel. So you need to know your local epidemiology when treating breakthrough infections. We performed, of course, antifungal susceptibility testing in the majority of isolates, although this had to be a sent-out test that uses these, so we did not have a mold susceptibility testing in-house, unfortunately. And we found, that a lot of Fusarium and Lomentospora isolates, nearly all of them had very high MSCs against voriconazole or posaconazole. So azoles as monotherapy were not really good options for treating these infections. And we also found that there was very high 180-day mortality, which, however, was significantly lower among those who received the combination therapy versus single-agent therapy. Of course, you may argue there's a significant difference, with much, much higher 90% mortality in monotherapy versus much lower mortality in combination therapy. But what does this mean with this low sample size? And this brings us basically to the end with these rare and orphan pathogens when we look into single center data. So we need to kind of like go global and look into the global amount of cases for these rare pathogens. Fungiscope is one option which we used here, which really collects globally infections by rare fungal pathogens. And we were able to increase our sample size for Lomentospora alone, which of course was important to differentiate these rare mold infections to 41 cases, nearly all of them proven. And what we found when analyzing all these 41 cases is that the combination, particularly with voriconazole and terbinafine, was associated with better survival versus any other antifungal therapy in these patients, in these 41 patients. And this was also significant in Kaplan-Meier analysis. Nevertheless, of course, this is of course some strong and it's already worldwide evidence, but optimally we would just have guidelines without having to do this work for every single rare mold we're identifying in our patients that show us what to use in these patients. And this needs to be up to date. And this brings me, of course, to the next point of my talk, which is what are the actual recommendations that are displayed in these guidelines and that then can help clinicians or laboratory staff. I'll continue here with Lomentospora prolificans, because here now we have up-to-date guidelines published in 2021 and really summarizing evidence up to 2020, late 2020, that first of all, we need surgery. Of course, we need remove of indwelling devices. And then we really should start voriconazole-based combination therapy with terbinafine. We can use voriconazole monotherapy in immunocompetent or localized infections. We always need to use therapeutic drug monitoring. And it's not just recommendations based on expert opinion. These guidelines have really an extensive supplement that shows you all the literature, the published literature that these recommendations are based on. And these are many thousand references. So also these guidelines kind of like save you to do a literature search yourself, but really may serve you as a literature review of what has been published, and you can easily go into every single paper showing why these recommendations have been made. What we also should not use, and this brings us back to changing drug classes, for Lomentospora prolificans, we should not use liposomal amphotericin B, and particularly, of course, no liposomal amphotericin B monotherapy. So in these patients who may have received, for example, ibuproconazole or isavuconazole and then developed Lomentospora prolificans breakthrough infections, changing drug class to liposomal amphotericin B would actually be an error. So that's why it's so important to isolate the pathogen and to really adapt the treatment to a pathogen that you have identified. And then, of course, there's also some recommendations, and you see these colors. Green means strong recommendation, versus yellow means more moderate recommendation. Orange means a marginal recommendation. That's mostly based on single case reports because there's just not a lot of literature. And red means actually recommended against. I see here liposomal amphotericin B for Lomentospora prolificans. But even for progressive disease, you have some guidance. What are you doing if a patient is not responding to first-line therapy? What can you use as second-line therapy in these patients? Fusarium is another example that's also been dealt with in the rare mold guideline published in Lancet Infectious Diseases with me as first author, but really more than 40 authors that have been centrally involved, including authors from Israel. And of course, it goes very much into detail for diagnosis of all of these rare mold infections. I mean, there is an extensive supplement with more than 100 pages, a lot of these very busy tables that show exactly for which rare mold infection, which diagnostic algorithm should be used, and which diagnosis has been described and can be recommended. This is just an example of one of these algorithms for fusariosis, where we kind of like differentiate between different patient populations, recommend imaging, but also recommend some biomarkers. So for fusarium, for example, we can use galactomannan, which results positive in some of these patients. So it's something that can be valuable. Sometimes also beta-glucan can be valuable to do in these patients. Of course, we want to use direct microscopy, culture from sites, blood cultures, definitely a very important diagnostic for fusarium. In contrast to many other molds, but fusarium is growing in blood usually. Histology, and then we always need further species identification, for example, by IDS1, IDS2 sequencing, DF1 alpha sequencing. And we also can use the MALDI-TOF. In terms of treatment for fusariosis, many of the evidence is based on studies published by Marcianucci that first showed, of course, that voriconazole therapy is equally effective as liposomal amphotericin B or other amphotericin B lipid formulations for treating. So we have now two first-line options basically, and combination of both may also be something that's very attractive. Given a more recent study by Marcianucci and many colleagues from around the world published in JACC in 2021, where First of all, there was no correlation found between outcome and Fusarium MICs against voriconazole and liposomal amphotericin B, which also tells us that MICs in some of these rare molds are not that reliably associated with clinical outcome. But what's really interesting is go into detail and look into these patients, particularly with very high MSCs against voriconazole and liposomal amphotericin B, who survived. And it really seems that in many of those combination therapy with voriconazole and liposomal amphotericin B was given, potentially resulting in this, surprisingly good outcome in these patients with very high MSCs. So what are we using? How is the treatment algorithm for Fusarium now looking like? We definitely want to recommend surgery, of course, removal of indwelling devices, and then we can use either voriconazole or lipid formulations of amphotericin B or a combination of both. We again have to do therapeutic drug monitoring. And if we start with combination therapy, we could think about stepping down to monotherapy once we get back the susceptibility results and we see MSCs for voriconazole and liposomal amphotericin B. Again, these recommendations can be adapted should you not have, for example, lipid formulations of amphotericin B available. These recommendations can be adapted to your setting. Also, in terms of treatment duration, a very common question because Fusarium infections are so rare. But I mean, that's also something where the supplement of these guidelines will really help you and really show you how long to treat. In hematologic malignancy, it's basically until resolution of neutropenia. But then in other clinical manifestations in other patient groups, it may differ, and it really shows you the recommendations, the quality of evidence, which is mostly, of course, low quality because we are missing big studies on duration of treatment. But it also shows you the references. So you could go back to the original papers, and you see this is often case reports or small case series with 24 cases for eye infections by Fusarium, where we say 6 weeks to 7 months is the treatment recommendation. And then, of course, looking into the supplement, we also go into children, which makes these rare infections even rarer. So this is mostly basically single sample, single case reports, or very small case series, 4 or less patients. But nevertheless, it shows you and summarizes you the different recommendations, how many publications were found, basically summarizing you all these single case reports or small case series and giving you a recommendation of what to use in children, because we have to treat them even in the absence of very strong evidence of what to use. And this is just 2 examples, but of course, the rare mold guideline goes into detail of many other rare molds and gives you also a summary table of what to use first line alternative, second line treatments to avoid, as well as salvage treatments. For example, Rhamsonia, if you have Rhamsonia infection, you should avoid Azole monotherapy, and you should really use Echinocandins. So all of this really, highlights how complicated this topic is here, are the other molds, rare molds that are dealt with in the guideline. And you really need to know your causative pathogen in order to make a good treatment decision on what to give your patient, because this really differs from patient to patient and from pathogen to pathogen particularly. Moving on quickly also to the rare yeasts. Here you can see some of the emerging rare yeasts that we are seeing also often as a cause of breakthrough infections. Geotrichium, Codamea, Rhododendron, Malassezia furfur, of course, and Sporopolomyces that may cause some of. What's very important is, of course, that again, not all of these rare yeasts may be relevant at your specific setting. And one of the strengths of the guideline is that also when you look into the supplement, there is specific worldwide maps that show you which of these rare yeasts occur in your setting. So for every one of these rare yeasts, it's shown where the cases reported so far occurred, which nations of the world, which continents, and it will give you some guidance on what's maybe relevant in your setting and what maybe not that relevant yet in your setting in terms of epidemiology. Moving on to treatment of rare yeasts, here you can see when looking into this table that liposomal amphotericin B, sometimes in combination with 5-fluorouracil, is really the #1 treatment for these rare yeast infections. But there's also important exceptions here. Here you see trichosporon, where for trichosporon we really want to use voriconazole and more or less rather avoid liposomal amphotericin B for treating tracheosporal infections. So again, it's important also here to know local epidemiology and also identify the rare yeast isolate that you're dealing with in order to make an informed treatment decision. Moving on to mucormycosis, which may be, of course, one of the more frequent ones of the rare fungal pathogens. And here we see on the global distribution of reported cases, which is very important to emphasize, because just because your nation is white here doesn't mean that they don't have mucormycosis. It may just be that none of these cases has been reported. And generally, we can say about mucormycosis, this is really occurring worldwide and a problem worldwide. It's an opportunistic fungal infections occurring, of course, in hematologic malignancy and ICU patients, but particularly also in uncontrolled diabetes or undiagnosed diabetes. And may in these patients also occur not only as pulmonary infections, but as venocerebral infections. Large outbreaks of mucormycosis have often been associated with natural disasters occurring after tsunamis or tornadoes, for example, the big tsunami in Southeast Asia in the early 2000s, but also tornado in Joplin, Missouri in the United States in 2011. It can also be associated with contaminated hospital products. Contaminated bed sheets or wooden spatula has been described as cause of hospital outbreaks of mucormycosis. And of course, it occurs after wars. And it's again, we have a lot of wars and increasingly wars, unfortunately, these times. So mucormycosis definitely something in soldiers that we have to with war injuries that we have to consider as important infections. How does the diagnostic pathway look like? And here again, we have these very useful diagnostic pathways in the guidelines, also in the in the summary, basically that is published in Lancet Infectious Diseases, and more extensively, of course, in the online supplement, where we see that we need, multiple radiologic imaging, chest CT, but of course also abdominal CT or cranial CT, depending on which form of mucormycosis we are dealing with: pulmonary mucormycosis, gastrointestinal mucormycosis, or venocerebral mucormycosis. And then, of course, we want to sample, we want to get biopsies because we don't have biomarkers available yet. We really need to get biopsies for culture and PCR testing. We can also now use PCR from blood, basically, and then we also want to always use direct microscopy, and we also want to use susceptibility testing because this particularly becomes relevant for some of these second-line options like isavuconazole or posaconazole that may not have activity against all Mucorales species. Radiographic signs of mucormycosis, of course, very important, particularly the reversed halo sign that we are often seeing basically here on chest CTs. Then, of course, and also here we have a reversed halo sign. The hypotense sign that we're often seeing here, and also vascular occlusion sign that we are seeing frequently in mucormycosis. But that may also sometimes occur in aspergillosis, I have to say. But mucormycosis, when muco is growing through, of course, we are seeing this. Typical for mucormycosis, the continuous spread, sometimes, through the diaphragm into the abdomen, from the lung through the diaphragm into the abdomen. And of course, the rapid progression that we can also, monitor in chest CT. First-line treatment, you again have these tables where basically you have the recommendations, strength of evidence, strength of recommendation, quality of evidence, and all the main scientific papers that have been used for coming up with these recommendations. But then we also have these algorithms that clearly show you, first of all, you also need to, involve a surgeon and see if surgical debridement or removement with clean margins is something that can be done. And then together, of course, you will start liposomal amphotericin B with a higher dosage, 5 to 10 milligrams per kilogram. If brain involvement, you would definitely go initially towards 10 milligram per kilogram. and don't start with a low dose and slowly escalate the dose, but really start with a high dose. If there is some pre-existing renal compromise that is worrisome, you can also think about isovuconazole or posaconazole, both IV, as first-line treatment with a response assessment. And then basically, depending on the response assessment, you can think about continuing treatment or, if you have progressive disease, escalating treatment, potentially also to combination therapy. Again, also here we have pathways because mucormycosis is an infection that occurs worldwide, for example, a lot in India. So if you are in a setting where you don't have lipid formulations of amphotericin B available, this also gives you a recommendation of what to use in this setting then, and this would be mostly isovuconazole or posaconazole then. Moving on, and this is really brings me towards the end of the guidelines that have been published so far. You've seen there's much more in progress, but endemic invasive fungal infections, again, lots of different societies that endorse these guidelines, particularly also societies from the Americas. And again, this guideline, also published in Lancet Infectious Diseases by G.R. Thompson and colleagues, goes into a lot of details, not only for blastomycosis, emergomycosis, coccidioidomycosis, histoplasmosis, paracoccidioidomycosis, but also all other endemic fungal infection, including penicillinosis, Dallemyces maffei infection, and really gives you detailed recommendations for diagnosis and treatment in these infections, which may of course also occur in some travelers that return from some of these countries, and as I showed you before, may be seen more broadly due to climate change and the general warming. So, and then I announced quickly in the beginning that there is also one other document that we gave out, and this only covers a proportion of the whole Aspergillus guidance. And this was really only focusing on COVID-associated pulmonary aspergillosis, which emerged rapidly in the early phases of the COVID pandemic and has been a problem since then. The problem we were facing here is that we didn't have good definitions that could be used for classification of the disease, and we also did not have good guidance in terms of diagnosis and how to treat this disease and when to treat this disease, most importantly. So we decided that we use our very effective methodology on establishing, in a very fast turnaround guidance documents also for this particular disease, COVID-associated pulmonary aspergillosis. Here are some radiologic examples. Of course, very difficult to diagnose radiologically because we already have COVID in the lung, which often results in, a very wide lung sometimes and a lot of different lesions in the lung that also sometimes could be, hidden aspergillosis. Therefore, we came up with these recommendations on what to do in order to diagnose COVID-associated pulmonary aspergillosis in this patient. And this, in this case, really a lot of it depends on mycological evidence. Histological evidence optimally, but this is really obtained in vivo. So it's often microbiologic evidence where this often really relies on bronchial lavage. So this is the most important thing. Do early bronchoscopy, obtain bronchial lavage in case of clinical suspicion, and also some evidence from blood. Basically, imaging is also something that's recommended, but here it's mostly about progressive disease, progressive COVID disease, because we don't have these typical imaging findings. The same for clinical factors. It's basically patients getting worse that is required for us to diagnose COVID-associated pulmonary aspergillosis. In terms of other evidence from respiratory specimens that are not BL, this is generally weighted less heavy in this classification guidance. So if you have tracheal aspiration or non-directed bronchial lavage, it's harder to diagnose it. Tracheal aspiration is not considered in this classification because of too many false positives, but non-directed bronchial lavage, if you have a combination of different diagnostic tests, may also help you to diagnose COVID-associated pulmonary aspergillosis. And these new classification criteria are definitely not perfect. They are definitely also work in progress and will need update. But nevertheless, it was shown immediately that these are very helpful in bringing the prevalence of kappa more towards what's actually been seen in autopsy studies and are more conservative compared to some of these previous classification systems that have been used. And most importantly, now they finally allow us to compare rates between papers because it's the same classification that is now used in the vast majority of papers. Of course, We also give detailed guidance for diagnosis and treatment of COVID-associated pulmonary aspergillosis. In this document, treatment, it's again voriconazole or isavuconazole, which are recommended as first line with liposomal amphotericin B, recommended as alternative agent for COVID-associated pulmonary aspergillosis. And with that, I really want to thank you for your attention. I have to say, of course, that all of these guidelines, many of them included 40, 50 plus authors, and all of these authors really contributed a lot of their time and a lot of their expertise into these guidelines and a lot of time also for literature research. And this is just to thank a few of those who have been involved in many of these guidelines. But we also try to switch around and don't have the same authors involved in all the guidelines. So we really have a large pool now of 300 or 400 different authors that are involved in our guidelines. So it's an exciting experiment that has so far really worked well, and we definitely look forward. Currently, we are working on Cryptococcus, Candida, and Aspergillus. So a ton of things, a ton of work that's currently ongoing and will be ongoing over the next year and a half. And yeah, with that, I want to thank you for your attention and looking forward to questions.